Welcome to MD Insights. Today I have Dr. Tom Augustin with us. He's an HPB surgeon at the Cleveland Clinic and the DDSI Digestive Disease and Surgery Institute. Dr. Augustin, you're an HPB surgeon. What is an HPB surgeon?
Well, Dr. Walsh, thank you for the opportunity to first participate in this program. It's a great honor. And thank you for being a chairman of the department. So hepatobiliary surgery, or HPB surgery, involves a set of operations on basically three different organs. It's the liver, the pancreas, and the bile duct. It is framed as a different specialty because of the complexity of these organs. There's a lot of complexity to the organs itself, but also complexity that happens because of the relationship of blood vessels to these areas. It tends to be a different specialty focus after a general surgery residency. It's a very exciting and great field to participate in.
Great. And one of your interests is liver surgery, is that correct?
Yes, absolutely. It's a fascinating organ. I always tell the story of Prometheus, where the liver regeneration story is highlighted. It's a fascinating organ. In a normal liver, a patient can have up to 80%, 70 to 80% of the liver removed, and it regenerates within weeks to months, depending upon how healthy the liver is to start with. So it's a fascinating organ. There's a lot of pathology in there with very varied diseases. So yes, I'm very fascinated with liver surgery.
Okay, and so let's talk a bit about some of the cancers that can occur in the liver. What are the more common things that happen that involve cancer?
Yeah, it's a great question. So it really starts with whether or not the patient has a normal liver. In patients who have livers that are not afflicted with cirrhosis or with hepatitis or other chronic issues of the liver, fatty liver being very common nowadays, very often their cancers, and specifically cancers, tend to be things that have spread to the liver. Since colorectal cancer is really one of the very common cancers that we encounter nowadays, a lot of the disease that I would see in a patient who's otherwise healthy has to do with colon cancer that has spread to the liver. On the other flip side is the patient whose liver is not healthy to start with. These may be patients with hepatitis who have gone on to have cirrhosis or alcohol disease or fatty liver disease. And in those patients, we see cancers which start in the liver, not a spread, but start in the liver. So those are cancers like hepatocellular cancer, again, a cancer of the bile duct called cholangiocarcinoma. Those tend to be predominantly, I would say, cover 90%, 95% of all the cancers that we see in the liver.
Okay, and as you mentioned that colorectal cancer is one of the common cancers that spreads to the liver. How does it get there exactly?
Yeah, so it's a liver is one of the great I guess stop stations for blood that drains out of the bowel, bowel being small intestine and large intestine being the place where colon cancers start. So all the blood that comes is cleaned out from the bowels and the colon will run through this big blood vessel that goes through the liver. And as it gets cleaned out in the liver, this blood gets detoxified in the liver. That's what the liver does, and goes back to the heart. En route to it, the liver tends to be a repository for these cells that are coming out, which have the cancer cells in it. And I think understandably, liver ends up being the site where many of these cancers show up as the first site.
Okay, so sometimes even if a cancer spreads from the colon, the liver is the only site that's involved?
Yes, as a matter of fact, outside of lymph nodes, the solid organ that tends to bear the brunt of spread from liver, so-called metastasis from where the cancer initially started, liver tends to be the most common organ to have these spots.
So as much as you like to operate on the liver, especially in colorectal cancer, you would still recommend that people get screening colonoscopy to prevent colon cancer, correct?
Oh, absolutely. Absolutely. I think there is nothing like prevention. as soon as you have a cancer, unfortunately, you fall into one of those statistics. None of those have a normal life expectancy. Every statistic has an expectancy which is shorter than what you would be expected to live without a cancer. The only way to prevent a cancer would be to catch these polyps early on, get those removed so that one doesn't have to worry about cancer of the colon. This is especially true if your family history is quite suggestive or high risk. If you have especially younger relatives with colon cancer, you should go for your screening sooner rather than later. And obviously, it's very important not to ignore any symptoms that you may be having. For example, bleeding from below, losing weight, losing your appetite. You should definitely see a doctor for those symptoms.
But if you have colon cancer and unfortunately the liver's involved, that would be an advanced stage of colon cancer, correct?
Yes. Unfortunately, it would be what we would call a stage 4 cancer. All cancers are staged 1 through to 4, and 4 being the most significant stage. Now, I will say, though, that much as we want to put a lot of people with cancer that's spread in that stage 4 group, it itself is composed of patients who may have maybe one spot in the liver to having numerous spots in the liver, or cancer that's spread outside of the liver to other organs. And not every stage 4 behaves the same. So for example, a patient with just one small spot in the liver is a completely different patient than, let's say, 2 spots or 15 spots.
So I know we could talk at great length about sort of what's happened in treatment for metastatic colon cancer over the last couple of decades. What if you had to highlight a few things that have really been game changers in terms of cancer care in metastatic colon cancer to the liver? What do you think are some of the important things, short of surgery, excluding surgery right now?
Oh, excluding surgery. Okay. Well, I think what has really changed has been the advancement in chemotherapy. I think that's been a game changer. I think that's one of the things that has actually given the disease a positive, I mean, obviously outside of not wanting to ever have cancer, but in patients with cancer that has spread, chemotherapy has given these patients a huge lifeline. There also has been significant advancement in studying the genetics of these cancers, and immunotherapy and genetic-based treatment, mutation-based treatment has also come into the forefront in the last 5 to 10 years. That's the medical aspect of it, and I think there is also a much better understanding of who are the patients who benefit from chemotherapy, when to time it, should it be before the surgery, should it be after the surgery. And I would also put in that non-surgical box treatments that are directed through the blood vessels. For example, chemotherapy that can be given through the blood vessel is an advanced treatment for some patients who may not have other options. Radiation treatment that can be given through the blood vessels is also another option. And finally, radiation treatment from the outside, the regular radiation treatment for patients who have tumors in the liver which are spread. Again, a significant advancement in the last many years.
So let's take the scenario of a patient who unfortunately has colon cancer, and at the time of diagnosis, they are found to have metastases or spread to the liver. What do you think are some of the options people should be considering, whether you're a surgeon or a patient in that scenario, in terms of how to handle the colon cancer versus the liver metastases?
Yeah. That's it's, you know, I think the key thing is to get the best possible team around you. And that team should have a medical oncologist, that's a medical cancer doctor, a surgical oncologist, or an HPB surgeon, that's a surgeon who tackles the liver, and then a colorectal surgeon, a surgeon who tackles the colon, and maybe a radiation oncologist if needed. I think given the complexity of just about every patient with stage 4, right? We're talking about patients who have had a stent, so all of these are stage 4 patients. These scenarios can be quite complicated. some situations we would actually go in and remove both the colon cancer and the liver at the same time, the liver tumor at the same time. Sometimes we remove the colon first. This is especially true if your colon cancer is causing a lot of trouble. For example, blockages or bleeding, we would want to remove that so that you have a better quality of life, and then take care of the liver after you get some chemo. And in some cases, you just do chemo, let everything settle down, and then go in and remove the colon, the liver, or together, or in sync, or one after the other. So I think the key thing for a patient would be to get that team, get a good tumor board that can look at everything, get a comprehensive testing, and last but not the least, also consider based on their age whether family members should get tested or not.
So you would certainly highlight the value of multidisciplinary care for everybody with advanced colon cancer.
Absolutely. And I would highlight the importance of multidisciplinary care, even if you have a suspicion that it may be an advanced cancer. Sometimes these patients have scans that show up with suspicious spots that may or may not be cancer. I think a good surgeon and a good team has to be involved to make sure whether or not one of the spots in your liver may be a cancer or not. And that may not be just a colorectal surgeon who may be able to figure that out. You definitely need more expertise in some of these situations.
So is there an ideal patient that you would suggest have simultaneously resection of the colon metastasis and the colon cancer at the same time?
Yes. The ideal patient would be someone who has a colon cancer, but he's not, or he or she is not very symptomatic from the cancer, and symptoms from the cancer could be blockage symptoms or bleeding symptoms. And then they have maybe 1 or 2 spots in the liver, not a lot of spots, things that can be removed with a smaller liver operation, something that's considered a little bit more minor. I think it's not generally safe to combine a major liver operation with a major colon operation because of the risk of infections that can happen. But I think the ideal patient is preferably someone with a colon cancer that's not symptomatic and limited disease in the liver.
So let's talk about some surgical options. What are the newer surgical approaches to patients with metastatic colorectal cancer?
Yes, and I think in that I would highlight ablation, the role of ablations. In this, the technology involves using laparoscopy, so small incision, minimally invasive surgery. Very often a surgeon is able to place a microwave needle under direct ultrasound guidance into a tumor and use that to ablate or destroy a tumor with heat. It allows us to tackle patients with multiple tumors in the liver. For example, I said while a patient can have 70% of the liver removed and still be okay, sometimes you may not be able to leave that much. In those cases, you may be able to combine removal of a lesion via surgery or cutting the liver and an ablation to do more advanced procedures. The second one I would highlight is laparoscopy in general. Laparoscopy has taken off in liver surgery, especially at advanced centers like the Cleveland Clinic. And major liver surgeries are able to be performed through small incisions. Sometimes we're able to remove an entire half of the liver. With laparoscopy, it affords the patient the same benefits that you would have if you were to have your gallbladder removed, for example. It's a little bit faster recovery. The incisions are a little bit smaller. Risk of hernias is a little bit less. And the benefit from the cancer operation is the same. And the third thing I would highlight is the role of transplant. These are for patients who have disease that is quite extensive, but the disease is limited to the liver. In those cases where you have no expectation of being able to remove the cancer because you would not have enough liver left behind, those patients have now an option to have their entire liver removed and have a new liver transplanted with really good outcomes. So it's something that's just been studied and the data is out, and I think it will be super exciting for patients who may otherwise have no options 5 years ago.
So is ablation with microwave equivalent to removing the tumor in the liver?
Yeah, I think it's a question that a lot of patients ask me. Overall, I would say yes for the very, very well selected patient. So for the patient who has a smaller tumor, somewhat less than 3 centimeters in size, it's not located in the depth of the liver, and it's not located on the outside surface of the liver. So somewhere in the middle, and generally meeting other criteria. For example, it's not really close to a large blood vessel. In general, I think it's safe to say that in that well-selected patient, resection and ablation should have comparable outcomes. Having said that, I think that even among these patients who may be well-selected, surgery may sometimes be a better option, especially if you're able to offer it laparoscopically. I think it's all about balancing the risks of the operation that you're offering with the benefits. I think the ablation benefit of an ablation is that it can be combined with major colon surgery. And the benefit of surgery and removal is that it may just be a better option for many patients. So I think here again would highlight the role of a multidisciplinary team for every patient.
And speaking of laparoscopy, other than surgeon skill, what other things do you think are important factors in deciding whether a laparoscopic approach is the right approach for a patient?
Yeah, again, a very common question that a patient would ask. I think the surgeon needs to be also skilled in ultrasound. So I think that's, again, a surgeon skill. I would just make that a minor point. But from a patient standpoint, sometimes they have cancers of the colon that need extensive open operations. Obviously, that would be a scenario where it would just be better to just do both surgeries open for the sake of efficiency and not having the patient on the table for too long. The second scenario may be the patient who has an acute symptoms. For example, the patient has a perforated colon from a cancer, and then you're going in many months later where you may encounter a lot of scar tissue. That may be another situation where an open surgery may be considered rather than a laparoscopic surgery. The older the patient who is in their 70s or 80s or is somewhat frail, maybe you're a perfect candidate for laparoscopy, even if it's a little bit longer. Their recovery may be much better if smaller incisions are used. So I think there are some nuances, even broadly speaking. Even if laparoscopy is generally applicable, there may be patients who are not good candidates because the surgery is quite extensive, or the patient may have previous surgeries where laparoscopy is not feasible.
So you did mention that the liver is unique in being able to regenerate itself. How does that play into surgical options in this day and age? So I think the most obvious application of it is that for patients with quite an extensive disease, in one shot, you can safely remove a lot of that disease using a combination of resection where even you could remove majority of one lobe or an entire lobe and half of the other lobe and still be okay as long as you're leaving 20-30% behind. And I say 20-30% because it sort of depends upon how healthy the liver is to start with, how much chemo you've had, and things of that sort. The second application is where we can use artificial means. I guess artificial is just a relative term, but if you can force the regeneration of the liver. You can force a side of the liver to grow artificially by decreasing or blocking the blood supply to the other side. So for example, if you want the left side to grow, you can have a radiology doctor go in and block the blood supply to the right side, which causes really only minimal side effects for most patients. And then that left side will grow and allow you to remove a lot more of that right side.
And the third application is probably a more advanced application, is where you're able to just divide the liver but not completely separate the liver, and you can force regeneration of the liver, which is quite robust and extremely fast. Within a matter of weeks, you can have a liver that's much bigger than what you started off with. I think some of these are really advanced operations. Some of these are also very serious operations with morbidity. I don't mean to mention any of these lightly. These are all very serious operations, but there are also operations that can be helpful for that occasional patient who needs more than less.
So that last surgery you mentioned was ALPS procedure. And is there a good way to decide who should get that versus embolization of the portal venous system to help the opposite side hypertrophy?
There is, yes. So I think ALPS is currently not, I wouldn't say it's mainstream at this point. So it's utilized more for that younger patient where you just need a rapid hypertrophy, as opposed to the portal vein embolization, which is a lot more mainstream. The other thing to think about is the use of chemotherapy. Sometimes portal vein embolization can be done while the patient is undergoing chemotherapy, which will allow the liver to regenerate during the period of 3 to 6 months that the patient is on chemotherapy, and allow you to do things that otherwise you wouldn't be able to. Yeah, I think there are some considerations, but I would just say that portal vein embolization, or that first procedure where the blood supply is blocked, is probably more common.
So given the improvements in chemotherapy, what do you do with the patient who has a liver lesion and it completely goes away with chemotherapy?
Yeah, I think that's where, again, the role of that multidisciplinary team is really, really critical. If the patient has a lesion that's, let's say, a centimeter in size or quite small in size, my bias would be to just remove it, ablate it, resect it before the patient starts chemo, if at all possible. That's because around 80% of these tumors that disappear with chemotherapy will come back, and they can often present conundrums regarding management if that happens. The other option, if chemotherapy has to be done, is to mark these lesions with small metal clips that can be placed by a radiologist, so that even if they disappear, we can find the clip with an ultrasound and sort of take care of the area where the cancer initially was. And obviously the third option would be, which I don't know how I feel about that, would be to just wait for these tumors to show up. If they do, 2 out of 10 chance they would not, 8 out of 10 they would, and if when they show up, we'd take care of them.
What do you see in the future that's exciting for liver surgery for colorectal metastases?
Well, I'm actually excited about the role of transplant, which has come about for patients who have a pretty advanced liver disease. We have had colleagues with that kind of disease presentations, really young patients that we see very often with very significant liver disease, which is not resectable. I am super excited to see what transplant surgery can accomplish in these usually young patients with very severe disease burden, and how much we can prolong their lives. I think that is very, very exciting. And then, I think the entire concept of being able to avoid an operation, what if, these lesions never come back, the ones that disappear, especially in patients with smaller disease and burden in the liver. So I think there's a lot on the forefront. I have to say that it probably will be more based off of chemotherapy. But from a surgical option, I think transplant is something that would be exciting for a patient population that we couldn't do much with.
Great. Well, thank you very much, Dr. Augustin. I can tell your passion for the field, and thank you for joining us on MD Insights today.
Thank you so much. It was really a great opportunity and a great honor. Thank you.